Good. Well, good afternoon, everybody. I will call to order this meeting of the statewide substance use response working group for October 9, 2024 at 2 p.m. Would you please call the roll?
Chelsea Cheatham. Dr. Dixon. Senator Doniate. Attorney General Ford.
Here.
Assemblywoman Hardy. Dr. Shayla Holmes.
Yeah, there we go.
Present.
Jeffrey Iverson. Jessica Johnson.
Present.
Dorothy Edwards.
Present.
Nancy Lindler.
Present.
Debbie Nadler.
Present.
Angela Nichols.
Present.
Christine Payson.
Christine alerted us she may be a little late.
Okay. Eric Schoen.
I'm here.
Steve Shell.
Here.
Dr. Beth Slamowitz.
Present.
Senator Jeff Stone. Assemblywoman Claire Thomas.
Here.
All right, Mr. Attorney General, we do have a quorum.
Very good. Well, again, good afternoon, everyone. Great to see or hear your voice over the phone. Let's move to agenda item number 2, public comment. We will receive it in person at either location and via Zoom. We'll limit public comment to 3 minutes per person. No action may be taken upon any matter raised during a public comment period devoted to comments by the general public until the matter itself has been specifically included on the agenda item as an item upon which action may be taken pursuant to NRS 241.020. Am I supposed to read anything about the dial-in number? It's not.
It's up there.
Oh, it's up there. Oh, okay. If you are dialing in from the telephone, dial 719-359-4580. We're prompted into the webinar ID 841-1615-6896. Then enter the meeting passcode, which is 676835. And then please press *6 so the host can prompt you to unmute. If you're joining virtually with the computer audio, please use the raise hand feature to indicate you'd like to provide public comment so that the host can prompt you to unmute. Before commenting, please state your full name for the record. You can also email comments to lhale@socialent.com. These comments and questions will be recorded in meeting minutes. So do we have anyone here for public comment in person?
Giuseppe Mandel, Desert Hope and American Addiction Centers Treatment Center. First, thank you guys for having me. I do appreciate it. I'd like to first say that my comments may not necessarily reflect the company that I work for or represent. It's more of a personal issue that I think that all these brains can help find solutions for in the future. I wasn't come with a list of a few people who have died in some of the high schools as of recent. I decided not to do that and just bring my personal experience because I'm not afraid of stigma. And just recently I had my son have to go to treatment in the school district. We sent him to treatment. We know we're lacking a little bit in the state. We're getting there. But since he had to go out of state, kept up with the schoolwork and everything like this, when we get back to school, we work so hard, guys, every one of us, in trying to implement ways and prevention and to help. And, when you got the situation where I hear a lot about harm reduction, a lot about prevention, and that's all great, but it starts with the youth and the youth of our state, this great state, the youth of our country, and that's where it all starts. And we don't even have to work on much on harm reduction if we start with that youth first. They're not going to end up in the jail, God forbid, in a gravestone or over a fireplace like my brother who I lost. Okay, I mean, this is important stuff. And when we got kids that are doing all the right things, they're up to date with school, and for some reason of lack of information, we can't figure out how to keep that kid enrolled, and we set him up for failure when he comes back. I'm not blaming anybody, right? We all work hard. I'm just saying we need to find a solution to it. Now, I'm working on finding a solution to it, but keep in mind, my other half has a law degree. I work in the field and I'm having a hard time trying to work on it. So God forbid, talk about social justice, the single mothers or single fathers that are not as educated and are not as versed in the field, what are they going to go through? And it's not the teacher's fault. It's not the vice principal's fault. It's not the principal's fault. It's somehow a lack of communication between all of us and being able to understand the bills that are passed or the laws that are put in place to protect these students and their mental health, but nobody knows how to implement them when we get to that part. I think, I don't know the answer. Like I said, I don't know it all. I just have my experience to bring. And God, I brought this up 2 years ago and God, our youth are so important. And I'm not just saying that because now it's my son, but he's got everything that we've implemented. He's got a sister that's the face of the Risk It All fentanyl campaign with the city of Henderson. He's got 2 parents who are well versed in the recovery field. And still yet, we found some opiates and some behavioral elements, whether it be due to COVID, there's no here nor there. But when we get him the help that we need and we get it implemented, we got to make sure that find some solution to help keep these kids alive so they're not set up for failure. And I hear that my son's case is unique because he's actually done everything that he's done and kept up to date with school. But that can't be true. It's got to be just of lack of knowledge, of lack of information. So I encourage all of us here and keep in mind, I work for a private company. So I've got no personal interest other than the better of the community here, right? I don't compete for grant funding. We don't necessarily work much with Medicaid. We're here for the better of the community. And God, this time it's on my own doorstep. And I lost a brother already once to fentanyl. Okay. I don't want to share another Thanksgiving with another vase of my son with ashes in the desk over the Thanksgiving dinner table. Right? I want to set these kids up in the future kids of this country. So please, I encourage us. I know we got an agenda here, but I do encourage that it is a pressing issue because if we fix the youth now, we don't have to worry as much. And I say as much about jails, institutions, harm reduction, treatment later on if we catch them early enough and we set them up for success. Okay. With that, thank you. And again, I don't necessarily come here from representing my company. I come here as a concerned parent, person in long-term recovery, grieving brother, and scared parent. Thank you.
Mr. Mandel, I'm first off, so sorry to hear about your son, but I'm grateful that he is recovering.
He is. He's doing the right thing. I mean, he's doing well. We just got to keep it going now.
Yeah. And thank you for sharing that. It is duly noted for public comment purposes. And again, thanks so much for mentioning it. Anyone else here for public comment? See no one else in person here. Anyone in person up north for public comment?
No, we don't have anyone.
Do we have anyone
I
on the
have
phone?
my
for public
hand
comment?
raised. Can y'all not see my,
No, we can see it. Thank you.
Debbie
County
Nadler for the
Marshal
record? Is it, I don't know if
Yeah, I
it's
hadn't
working
gotten to
right.
you, Debbie. Just,
Oh, okay.
yeah, hold on, Debbie. I hadn't gotten to you.
Okay.
I was still asking
Thank
about the
you.
phone. Is there anyone on the phone for public comment?
I see a Marcy Trier with her hand raised as an attendee and then Debbie Nadler with her hand raised as a surge member.
All right, so let's go with Debbie since she already mentioned her name. Go ahead, Debbie.
Sorry, my phone's acting funny today. Thank you. I'm glad to be here today. Glad to see everybody. I was going to speak about the prevention and the education too. I've noticed a lot more incidences in schools. These kids do not know. I was a single mom too, raising my kids. I'm going to say at least 50% of our kids in schools come from a broken home. Not that that causes substance use, but you've got parents working twice as hard, not able to educate their kids, who don't know enough to educate their kids. As everybody knows, I lost my son. I wish I had known more. But we have to start with the youth. We have to. If we do not prevent this, prevention is key. I mean, I'd rather pay $12 per kid per year than $48,000 for a funeral. I've looked up every bill that's passed. I have literally gone in to Legiscan and looked up every bill that's passed. I know there is stuff supposed to be happening in our school, and it's not. It's really not. I have parents calling me all the time. What do I do? What do I do? My 12-year-old is using, my 13, my 14, my 15-year-old is using. Giuseppe, I am so sorry. I'm glad. I hope your son is doing better. I understand how you're feeling. I felt that way and I feel that way now. And we have got to do something with our school systems. We have to. It's imperative. Thank you.
Thanks, Debbie. And who was the other public comment?
There's a Marcy Trier.
Ms. Trier, come off mute and go ahead and give us your public comment.
Oh, okay, thank you. Hello, my name's Marcy Trier, and I represent the Division of Children and Family Services. I am a duly licensed alcohol and drug counselor and mental health counselor. I have worked 6 years with Mobile Crisis as a crisis suicide responder, but with my background as a licensed drug and alcohol counselor, I am here on my own. I found you on my own because I want very much to advance the knowledge and education of substance abuse treatment for our youth here in Nevada. And I'm not sure if there even is currently a drug and alcohol specialist. I don't believe there is one in DCFS. And so I'm just wanting very much to help advance this education and knowledge and all the hard work that you all are doing to help spread it across our schools and all of our public settings for our youth, because I do believe there's this huge correlation between suicide and substance abuse, violence, school violence, and etc. And so I'm just here to support you all and also see how I can also help contribute and collaborate with you all, because I just feel that substance abuse is really lacking, especially among as hard as everyone works, mental health is being addressed, but substance use treatment is really it's just not being addressed as fully as I believe it should be. And I know that because I used to go to all the emergency rooms and treat these kids, and there really are there are very minimal settings for substance abuse treatment. So I am truly just here to support you all and all the hard work you do and see how I can be of any assistance. Thank you.
Thank you so much for your testimony. Greatly appreciate it. Anyone else on the screen for public comment?
No, sir, I don't see anybody else with their hands raised.
And we'll come back here to Vegas. I think we have additional public comment.
So it's a little late, and it occurred to me, maybe I should report what happened today in my clinic.
Please state and spell
Oh,
your
I'm
name for the
sorry,
record.
Dr. Leslie Dixon, a member of this committee. So I work in substance abuse treatment, as some of you know, and so I have students and residents and all kinds of learners working with me off and on, and so one of mine today is a medical student. He's very interested in pursuing a career in emergency medicine. And he was telling me about going out on a call with EMS and stuff in responding to 911 calls of overdoses. And so they go out and they see these overdoses, and frequently somebody has already given them, the person Narcan, which is great. Woke them up, or they will give the person Narcan and wake them up. Half of those people refuse to get in the ambulance or go to the hospital. They are angry or just thankful that they're alive and they go. I guess it kind of brings home two things. One positive thing, that Narcan is clearly out there to be used like that. But second is that, at our clinic, we just don't have that many new patients, people coming in for treatment, and I can put a little bit more perspective on why. They're just not ready to give up using. And these are usually fentanyl overdoses probably, but anyway. A little perspective on what's happening out there on the streets.
Thank you. Thank you so much for sharing that. Any additional public comment? All right, hearing and seeing none, we will move on then to agenda item number 3, which is a review and approval of our minutes from our July 10th, 2024 SURG Meeting. And they have been distributed. Once you are ready, please, I will entertain a motion to approve the minutes.
I have an amendment, a spelling error to correct.
Okay.
On page 3, the next to the last paragraph, it says she will work together with Dr. Strong. Well, it's actually Dr. Strom, Strohm. Just in case someone should ever see that and want to find
Yeah.
Dr. Strong.
Great, thank you.
Uh,
Any additional comments? All right, I'll entertain a motion to approve as amended.
Christine
Dr.
Faith,
Dixon,
I'll move to approve with the noted correction.
All right, I'll take that a motion from Christine Payson and the second from Dr. Dixon. Any discussion? You can see none. All in favor will say aye.
Aye.
Opposed, say nay. Motion carries. Thanks so much. All right. moving-
For
Yes,
just
ma'am.
of note, obviously, Dr. Dixon is here and Christine Payson are both here. They weren't on the original
Oh,
call.
Okay, right
So
on.
to add them.
Thank you.
Mhm.
And as well as Chelsea Cheatham.
All right. Okay, moving on to agenda item number 5, this is an informational item, noting that we have appointed Senator Jeff Stone to the SURG Committee and to the Response Subcommittee. As I understand it, he's been actively involved since August 6th on the Response Subcommittee, but I want to make that announcement known to the members of the committee. And with that, we'll go to agenda item number, unless, were you gonna say something? All right. Agenda item number 5, the Department of Health and Human Services status report on SURG recommendations. We have it slotted for 30 minutes for information and discussion. We'll give it over to Laura Hale. Laura's going to present highlights of the updates and note the following individuals are available to answer questions. We'll have Stephanie Cook from the Bureau of Behavioral Health, Wellness and Prevention, the State Opioid Treatment Authority. We'll have Don Yohe, Clinical Program Planner 3 from the Director's Office. We will also have Kelly Quintero, Grants Manager, Fund for Healthy Nevada. And we'll have Beth Scott, SUD Treatment Policies, the Division of Health Care Financing and Policy, and Dylan Nall, I believe it is, Social Services Program Specialist 3 at DCFS. So with that, Laura, I'll give you the mic.
Thank you, Chair Ford. So the handout with the status update should be on the screen, and others may have a hard copy as well. So I just wanted to hit some highlights and to explain, if you look across the top there, so you've got a couple of programs within the Director's Office for the Department of Health and Human Services. So there's the Fund for Healthy Nevada, which is tobacco settlement dollars, but they do things beyond tobacco settlement with that. So there's some information from them. There's the Fund for Resilient Nevada, which is just the opioid settlement dollars. So that's with Don Yohe. And then there's the Division of Child and Family Services, which touches on some of the issues with their programs. There's also the Division of Healthcare Finance and Policy, which is also known as Medicaid. And then there's a Division of Public Behavioral Health. Within the Division of Public and Behavioral Health, there are multiple different bureaus. The primary one that does things associated with substance use is the Bureau of Behavioral Health, Wellness and Prevention. And so Stephanie Cook is here on that one. So just looking at that first one, I wanted to hit a couple of highlights. So these are recommendations from 2023 for the SURG, and all of these different programs to some extent engage on SURG recommendations. So on the first one, you have from the Fund for Resilient Nevada with regard to doubling the amount of investment. So there is funding there for prevention coalitions and school-based services. There are also Family First Prevention Services under DCFS, and then under Public and Behavioral Health, that bureau, behavioral health, wellness, and prevention. They do currently allocate a minimum carve out of 20% for primary prevention dollars every federal fiscal year for the block grant as required by SAMHSA, which is their federal funder. And then if you skip down in that column a little bit, they also reference the Medicaid 1115 substance use disorder waiver that will allow some additional flexibility of funding for the block grant. And then if we can go to this next page. Thank you. So on this one, the recommendation was about allocating tobacco control and prevention funding using local lead agencies. And so within the director's office, again, that's that Fund for Healthy Nevada that has tobacco settlement dollars. The key grantee that's funded under that source is Southern Nevada Health District, which has utilized their funding for state fiscal year 24 and 25 for prevention and cessation of tobacco use, specifically e-cigarettes and other vaping devices. And then if you skip over to the last column, under the Division of Public and Behavioral Health, that bureau works with another bureau, I think it's Child, Family, and Community Welfare, to allocate tobacco dollars. And then there's also a Suitors Block grant, which requires support for tobacco-related activities. Skipping down to number 3 on that same page, you can see over there that the Bureau, again, has retail violation rate data relating to the rate of which entities sell tobacco products to youth, which is a little different from the outlet density. So they did offer to ask the Office of Analytics to have a dashboard for that type of information. So that's something that maybe the SURG members would want to follow up on to see if they would like that kind of a data dashboard. But right now they don't seem to have the other type. So then if we skip down a page to number 4, expand Medicaid billing opportunities for preventive services, blended braided funding. Quite a lot going on there under Medicaid. So the Children's Behavioral Health Transformation is promoting early screening and behavioral health concerns, many community-based services, family peer support, respite, wraparound facilitations that are expected to be implemented within the 2025-26 service year. And again, there's a reference to the 1115 service substance use disorder demonstration waiver amendment. That's going to be submitted to CMS in November. So there should be more information coming available on that to include psychiatric treatment, as well as integration of some health-related social needs. And then going on to number 5 on the next page, harm reduction, utilizing opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years in Nevada. And again, this is under the Bureau within DPBH. So the SURG grant, there is a state naloxone net saturation plan that's currently participating with various partners on a federal policy academy. And moving down, they're also going to research a data management system to allow for naloxone to be accessible by Nevada's community partners, people who use drugs, and all other stakeholders that want to access free doses of naloxone. And there are specific, the recommendation is specific to opioid settlement dollars. Those dollars are under the Fund for Resilient Nevada. So, you know, depending on how you write the recommendation, different programs, within different divisions may respond directly to that, but there are also programs that may be already addressing some of those items. Item 6, harm reduction.
Hey, Laura, let me stop you for a second. I'm gonna have to give the mic over to Mr. Shell, the vice chair, to continue the meeting for us. I have to do a couple of things. So, Mr. Shell, you have the chairmanship right now, okay?
Chair Ford.
Thank you. All right, thanks, everybody.
Thank you. I'll go ahead with number 6. So This was creating a recommendation to the legislature modeled on Maryland's STOP Act. And again, we got a response from the Bureau in Public and Behavioral Health. Happy to support this. The SURG grant supports leave behind programs for naloxone as people who use drugs are at the highest risk of overdose. Going on to item 7 on the next page. Thank you. Support harm reduction through implementing changes to recruitment, retention, compensation of health and behavioral health care workers. So that first item under the Fund for Resilient Nevada, that's actually, I think that was my error. It should have gone up up under the previous dollars, but it's referencing dollars that take the lead. So that was the previous recommendation that we had. So those dollars take the lead for that kind of work. Moving over to under Medicaid, they have an SPA under review with the Centers for Medicaid and Medicare to create a daily rate for substance use disorder residential services. The DHCFP, which is Medicaid, plans to submit for rate increases for outpatient behavioral health services, including peer support, by the end of 2024 to CMS. And then again, within the Bureau with Division of Public and Behavioral Health, they support the hiring, retention, training of peer recovery support specialists within its programs. They've also proposed for paying for their coursework as a part of the latest award application to bolster recruitment to the field, pending SAMHSA approval. And they also want to get those recovery support specialists embedded into various community supports, hospitals, treatment programs, et cetera. And then on number 8, again, with the Bureau within the Division of Public and Behavioral Health, they have proposed funding for a drug checking pilot program in Washoe County, modeled in part after Southern Nevada Health District's drug checking program and part of the latest award application. And then they say at the bottom, if approved, this project will move forward October 2024. So I don't know if Stephanie will have an update. All right, of course, we're just at the beginning of October, but she may. And so after we go through the summary here, she could add an update or people can raise that question. And then going on to number 9, next page. Harm reduction shipping supply, provide travel costs for pickup of used products to be returned for destruction. The SOAR grant currently funds a mail order harm reduction supply program via Impact Exchange Track B in Las Vegas. And then under number 10, again, harm reduction post-overdose outreach with public safety, including wraparound services. So this under the Fund for Healthy Nevada again. And one thing that I wanted to add, most of these programs are grant programs, so they may be within a set period of time, and they might get approved each year. Whereas oftentimes the Medicaid, when they get a SPA approved, or when they do different trials, those things, if they get embedded, those go on, into the future. So just to be aware of that. So under the grant with the grants management unit and the Fund for Health, actually this is there's a state general fund grief support trust account. So they fund Adams Place and the Solace Tree. And I think one of them is, Adams Place is in Las Vegas, and the Solace Tree, I believe, is in Washoe County. Services provided include bereavement services, individual and group counseling, peer support groups, family activities for children and families who have lost loved ones due to overdose. And I know we've had a lot of questions from SURG members about that in the past. And so if you're not familiar with that, we could maybe get some more information on those programs. DPBH over at the end there, the SOAR grant currently funds. So these are just 2 different sources of funding for Adams Place. So it's both under the Fund for Healthy Nevada and also under the Bureau and the Division of Public and Behavioral Health. Number 11, we didn't have any feedback from DHHS overall on drug, changing language around drug paraphernalia. So maybe in looking at bill draft requests, targeting who that goes to, might be helpful for new bill draft requests that you come up with, because they don't always fit in a particular slot for DHHS. Number 12, provide support to community coalitions to support community health workers to expand harm reduction throughout the state. So there's a reference here that the Fund for Resilient Nevada does fund Sharps and Sharps containers. And then again, under DPBH, this has been identified as a priority as part of the latest award application. And then also Medicaid has said that they would be happy to try to promote that work as well. Then on to 13. Expand access to MAT and recovery support for SUD. So you can see there's quite a lot that cuts across the different divisions that's going on here with grants under the Fund for Healthy Nevada, and they're funding federally qualified health centers that even though it's not specifically designated for a MAT, there are some community health centers like Community Health Alliance that utilizes their funding to support the building of a MAT program. Then down at the bottom of that same column, Southern Nevada Health District is also utilizing their funding to design and implement an integrated behavioral health model and coordinate with other FQHCs to identify and refer patients. And then, of course, Medicaid has implemented policy for telehealth services delivery to be clinically appropriate and medically necessary rather than to be limited to certain services. They've also built a brand new provider type, 93, to include opioid treatment programs along with other SUD clinical models. AB 156 required Medicaid to reimburse for MAT when provided by a pharmacist. So a lot of those things, again, that's something that goes on, well into the future when those changes occur with Medicaid. And then again, under the Division of Public and Behavioral Health, that bureau is working on finalizing recovery housing division criteria. They'll have a pilot project once it's approved to be completed in Las Vegas to fund recovering housing. Recent updates for 42 CFR Part 8, I believe that's part of the Federal Register. Telehealth and other flexibilities were permanently added. So again, another thing that would go on to the future to expand access to MOUD. And then let's move on to 14, implement follow-ups and referrals and linkage of care for justice-involved individuals. So you have Medicaid working on the Consolidated Appropriations Act to allow for justice-involved youth to receive Medicaid eligibility and receive EPSDT, as well as targeted case management services, pre and post-release, and that will happen in 2025. The larger goal, they say, is to implement that 1115 waiver to cover all justice-involved individuals, 90 days pre and post-release for additional services, including substance use treatment. And again, the Bureau funds FAST and most programs for the state to decrease recidivism, works upstream from the sequential intercept model. The Bureau also funds the Division of Welfare and Support Services with a recovery-friendly workplace initiative, connecting individuals to work and other resources upon reentry to the community. 15, implement special child welfare service delivery model. So in this one, this touches, of course, with the Division of Child and Family Services and the CARE program, where substance-affected infant referrals may include Early Head Start, Thrive by 5, Southern Nevada Health District, and Family Resource Centers. Again, with Medicaid, they're building up community-based services to children that meet at-risk criteria. Additionally, they're working to implement a health home for individuals with fetal alcohol spectrum disorder by the end of 24, and considering an additional health home model for pregnant individuals struggling with SUD. And finally, under the Division of Public and Behavioral Health, that bureau has a carve out of 5% for women in treatment programs. They also plan on working with Empowered to incorporate more peer recovery support services related to care plans of care. So there's some coordination that often occurs across divisions within the larger department. Moving on to 16, establish priority funding areas. And this is trying to reach special populations. And the reference there from the Bureau is they fund community-based organizations representative of underserved populations to conduct harm reduction activities. The upcoming requests for applications will help the Bureau make data-driven decisions to identify community partners and agencies that are able to provide services to specific populations. Item 17, increase capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and divert youth under the age of 18. Medicaid currently has a SPA under review to reimburse for substance use disorder residential services as a daily rate rather than based on individual service reimbursement. They also received approval to reimburse facility-based provider of intensive crisis stabilization services at a daily rate. And then the Bureau has funded youth residential care for the 8th Judicial District Court in the past year. So let's move on to item 18. Engage individuals with living and lived experience in programming design consideration and enhance peer support. Medicaid is initiating policy revision for peer support services and adding family peer support as an available service. Also, peer recovery support specialist is now a specific enrollment specialty. Medicaid is targeting a end of year SPA submission to increase reimbursement rates for behavioral health outpatient services that would include peer services. And the Bureau is supporting and funding peer support training and certification through recovery services with partners such as Foundation for Recovery. Item 19, evaluate current availability and readiness to provide comprehensive behavioral health services for screening, assessment, treatment, recovery support, and transitions, but not limited to just those things in local and state carceral facilities, and recommend allocation of funding to support the development of a Medicaid reentry Section 1115 waiver to increase healthcare for people leaving carceral facilities and support readiness of carceral facilities to implement the waiver. AB 389 requires Medicaid to apply for that demonstration waiver, and work has been initiated. And they actually provide a link there, so folks who are interested in following that can follow that link and get updates as needed. And then the Bureau has both funding for FAST programs in a few local jails through the state to decrease recidivism and work upstream again from the sequential intercept model. And then the SURG grant has proposed funding a needs assessment for the Department of Corrections related to the provision of MOUD services and related supports as part of the latest award application. Moving on to item 20, understand the true cost of implementing wastewater. That's not something that DHS responded to. They wouldn't necessarily have expertise in that area. 21, leverage existing programs and funding to develop outreach response providers and/or personnel to respond to suspected overdose. And then I'm just going to skip down to the bottom of the paragraph. Ensure this recommendation is included as the build out of Nevada's crisis response system is occurring so that tailored intervention for individuals who have survived a non-fatal overdose is included. And again, there's work going on under the Bureau within the Division of Public and Behavioral Health. They have a crisis response section in charge of overseeing the state's crisis response activities. And the regional behavioral health also assist with engaging the community with the needed resources. FAST and most teams also work closely with the jail systems to provide linkages to care. And then on 22, lessons learned from Clark County's overdose fatality review task force. When the report is released in December 24, take this into account when supporting legislation to establish committees allowing flexibility as to the makeup and practice, and for the OFR to remain at the county or regional level as needed to effectively identify systems gaps and innovative community-specific overdose prevention and intervention strategies. The Bureau is looking forward to seeing this report with the intention of utilizing it to inform programming in Clark County. And then the final one, 23, understand what coroners and medical examiners currently test for and make recommendations to a specific agency or other sources to fund personnel and resources for independent medical examiners for investigations and reports to specify the cause of death in overdose cases. The SURG grant has proposed funding the expansion of the drug panel used to test all individuals who enter Washoe County Medical Examiner's Office and Clark County Coroner's Office to include a broader array of opioids and stimulants. This data will be used with the public health lens to analyze the data and inform prevention and intervention-based programming. Also, there are OD2A funds for the toxicology testing conducted at Washoe County facilities, working with the coroner's office to gather the reports and conduct the testing. So there's a lot going on, and there are folks who can answer questions if members of the SURG have questions for them. Thank you, Mr. Chair.
Thank you, Ms. Hale. Do we have any questions for Ms. Hale today?
Chair, this isn't a question, but this is Terry Kearns. I just wanted to add, in addition, that obviously DHHS has taken recommendations from the SURG and used those. So please feel assured, members, that your commitment and work is being heard. And I also wanted to highlight that on the recent state opioid response RFA, funding priorities included the priority populations similar to those that are outlined for the SURG and that we look at, and that the SURG recommendations will be given a special consideration as part of that RFA. So again, your voice is being heard when you make these recommendations.
Thank you, Dr. Kearns. I see Ms. Nadler has her hand raised. I'll turn it over to Debbie.
Thank you so much. Thank you for that great presentation. I do have a question. On item number 21, if you could pull that back up on the screen. And I thought we had spoken about this before, adding some wording in 21 about the treatment for an overdose in emergency hospital room and offer follow-up support, referrals, and services. I thought, and I have it in my notes, that we had added for fatal overdoses, help for the family members. Jessica, do you remember this? Am I mistaken? I thought this is where we added help for those who, emotional help or behavioral help, for those who have suffered a loss.
Thanks. Chair, permission to respond?
Please do, yes.
Yeah, thanks. Jessica Johnson for the record. Debbie, thank you for your question. I believe that the and loved ones is included in the second part of line 2, following an overdose. So I believe that this is out of the move to the response subcommittee as part of our integration last December. I don't know if any other SURG committee members can corroborate that, but I believe that's how that was included for item number 21.
Chair Terry Kearns, if I may.
Yeah, please, Dr. Kearns.
Yes, and Jessica Johnson is correct that recommendation was added into the response subcommittee. And we did add the language that was highlighted about follow-up support, referrals and services to the individuals and loved ones following an overdose. So going along with that grief support, it was the integration of those two recommendations.
Thank you. I thought we had added the word "and fatal overdoses." We had added something to distinguish. I thought, I mean, I just want to make sure it includes both.
We just, I think, generically put overdoses to include fatal or non-fatal overdoses.
Okay. Thank you.
Any other questions or comments?
Chair Schoen, this is Jessica Johnson. I do have a question.
Yes, Ms. Johnson.
Or sorry, Vice Chair Schoen. I'm giving you promotion. My apologies. Shell, and calling you by my colleague's name. Clearly need more coffee today. Jessica Johnson for the record. First of all, I wanted to thank staff for the time that it took to prepare such a comprehensive report, and a big thank you to all the different bureaus and groups that are listed on here to identify all of these details. I think are very helpful as we consider implementation and sort of where the leverage is at. I was hoping, Ms. Hale, if you could scroll back to the first item on here, the prevention subcommittee recommendation 1. Thank you. A huge thank you to the folks at the Bureau who helped our subcommittee really prepare this specific recommendation around doubling the funding. Part of the details of the dollar amounts that are included in there include for sure the block grant dollars and some of the other grants that were in existence. So just to clarify, really the doubling that was recommended is to increase the reach of these programs across the state. And that dollar amount was arrived at with a lot of work on behalf of the Bureau. So a big thank you to the folks for that. My question though is on the comment regarding the Medicaid 115 substance use disorder waiver that had some flexibility of funding for the block grant around prevention. And I was wondering if someone could comment a little bit more specifically about what that means for a primary prevention focus, so our committee could take note.
Would anyone like to respond to Ms. Johnson?
Yeah, this is Stephanie Cook, Deputy Bureau Chief for the Bureau of Behavioral Health, Wellness, and Prevention. I oversee all the substance use programming within our Bureau. So traditionally, our substance use prevention, treatment, and recovery services block grant has been used to fill voids in our substance use community. Historically, this has covered a lot of residential treatment in our state. So the bulk of the dollars of the sub-grant, probably, I don't know, 65–70% of the block grant is paid out for residential treatment facilities. The reasoning is there was no other funding source. So there was no other way for Nevadans to receive residential treatment if they didn't have either really good insurance or a lot of money. And so we've spent a lot of our block grant on this service. So with the rollout of the 1115 waiver from Medicaid is taking over the cost of that residential treatment for anyone that has Medicaid. So we are currently on a track of only funding residential treatment fully through December of this year, and then rolling out the substance use disorder waiver, 1115 waiver with Medicaid effective January 1st. So what I mean by the comment here that it's going to allow some flexibility in our funding is when most of that dollar amount gets shifted off of our block grant, we will have more opportunities to fund other needs in our communities. Our Bureau is currently working on a strategic plan to identify what those up and coming needs are. And of course, taking in all these recommendations. And we know that going upstream with primary prevention is important. So it will allow us more flexibility to allocate dollars in that way.
Thank you so much. That's the clarification I was looking for. I appreciate it.
Yep.
Great. Any other questions or comments today regarding this agenda item? Okay, hearing none, we will move on to item number 6, which is statutory, regulatory, or administrative efforts related to SURG recommendations. This is for information and discussion. This is an opportunity to report on BDRs, regulations, or administrative activities from the Attorney General's office, and to gather information from other SURG members regarding corresponding efforts within their spheres of influence. So at this time, I believe I am turning it over to Ms. Teresa Benitez Thompson.
Thank you so much. So we did submit, AG Ford did submit as part of his cache of BDRs, the recommendation from this committee to increase the size of the committee. So we submitted it into Legislative Council Bureau as it was recommended by you folks with those 5 new positions. So that is in the queue. Additionally, while it's not a BDR, but on the budget side built for the Office of Attorney General, we are hoping to build in Terry Kern's position as a statewide opioid response coordinator as a permanent position within the Office of Attorney General. So those are 2 relevant measures that we thought we'd share out with you guys.
Thank you, Ms. Thompson. Do we have any comments from any? Oh, yes, please.
Vice Chair Terry Kearns, if I may.
Yes, Dr. Kearns.
The response subcommittee did have a presentation from the regional behavioral health policy boards, specifically looking at any BDRs they were aware of. So I just wanted to update on what I'm aware of. And if any of the other SURG committee members were involved with any of these, please feel free to add more detail or correct me if I'm saying something wrong. So the first one was from the Rural Regional Behavioral Health Policy Board. They have BDR 54-403, which revises provisions related to behavioral health. And it specifically enters the Nevada Board of Examiners for Social Workers into the newly formed Social Work Compact. And then it also revises language for annual licensure data reporting. So that was the first one. From the Washoe Regional Behavioral Health Policy Board, there's BDR S-405, which requires a study of mental and behavioral health care parity in Nevada and explores where Nevadan payers, public or private, are falling short in payment parity. Then from the Northern Regional Behavioral Health Policy Board, we have BDR 39-434, which revises provisions relating to peer recovery support services. It adds transition-aged youth as possible PRSS interns with supervision from certified peer recovery support specialist supervisors, and creates a workforce pool for the PRSSs and certified prevention specialist. Then from the Southern Regional Behavioral Health Policy Board, BDR 39-368, which revises provisions relating to providers of non-emergency secure behavioral health transport services. And then workforce efforts, mechanisms to reimburse transport companies for what's determined deadhead miles for improving business viability and staffing. And the deadhead miles are basically if they transport someone, then when they go back and they don't have anyone with them, that's the deadhead component of it. The next is the Clark Regional Behavioral Health Policy Board, has BDR 31-433, which revises provisions related to state financial administration. It's streamlining the federal grant processing and to avoid past discontinuity in service due to grant distribution lag time. Then some known legislator BDRs are Assemblyman Hafen and Senator Titus. Have BDR 129, which revises provisions governing healthcare. It will enter the Nevada Board of Examiners for Marriage and Family Therapists and Clinical Professional Counselors into the Counseling Compact. And the Joint Interim Standing Committee on Health and Human Services has BDR 352, which revises provisions relating to social work, the social work apprenticeship program within the Board of Examiners for Social Work. And then BDR 40-353, which makes revisions related to health professionals, establishing the State Office of Healthcare Workforce and Licensing within DPBH. It includes Behavioral Health Licensing Board, consolidating the current Behavioral Health Licensing Board, and explore other licensing board consolidation during the 2025-26 interim. And also BDR 354, which establishes priority review for certain applicants for licensure to practice health professionals, giving priority review status to the application of an applicant for a license or certificate who demonstrates that he or she intends to practice in a historically underserved community as defined in NRS 704.78343. An applicant shall provide proper documentation, including without limitation, a letter for an employer located in a historically underserved community, indicating that the applicant has accepted employment and stating the start date. The next one is BDR 358, which creates the Office of Children's Mental and Behavioral Health. And the purpose is to create the Office of Children's Mental and Behavioral Health and the Director's Office of DHHS to tie together all efforts and programming related to children's mental health and to remove existing silos and to make an appropriation totaling $1,113,364 from the State General Fund to DHHS over the 2025 through 2027 biennium for the personnel and operating cost of the office created in the department, and to make an additional appropriation of $15,000 for equipment and office supplies for 2025 and 26. Then the Patient Protection Commission has BDR 54-449, which revises provisions relating to certain providers of healthcare, looking at multiple interstate licensure compacts, including the nursing compact. They also have BDR 38-451, which revises provisions relating to graduate medical education. It established a new Medicaid healthcare workforce fund at the Division of Healthcare Financing and Policy to support efforts to expand the state's healthcare workforce, including but not limited to eligible graduate medical education programs, eligible indirect medical education programs, provider fellowship and apprenticeship programs, and loan repayment programs. And then BDR 38-450, which revises provisions related to Medicaid, thank you. And then the other behavioral health workforce development process, which is Be Here Nevada, resulting from AB 37 and the 2023 legislation, which finishes a hiring process, building programs, and preparing to build an advisory committee. I know that's a lot, and I can provide this information to the committee members as well, so you'll have it to follow those. Thank you, Chair, or Vice Chair.
Thank you, Dr. Kearns. Do we also have information being provided by Crystal Dwart? Not to put her on the spot, but.
Oh, yeah.
No, I don't have any information to provide.
Okay, thank you. So do we have any other questions or comments regarding this agenda item? Okay, I see
Uh,
Dorothy Edwards has her
okay.
hand raised. I'll turn over to Ms. Edwards.
Hi, nothing much. Dorothy Edwards for the record. I just wanted to thank several months ago, if not more, I had advised during one of our meetings, AG Ford, that I would I would do exactly that. I think it was Valerie, my rural region peer coordinator, that provided that presentation, and she's not on, but I thank her for doing that. I also have that information in front of me, and so should anyone want additional information on the policy board BDRs, I can seek that. In terms of Washoe, which of course I represent as our Vice Chair Shell, in speaking to our legislator, Assemblywoman Peters, at least she's still Assemblywoman now until November. We are hoping to get some language back within the week, and speaking to our legislative analysts. So that'll be exciting. So maybe by our next meeting, some of these will have grown up to be bills. So thanks, Vice Chair. I just kind of wanted to acknowledge Val for giving that presentation for me.
Thank you, Ms. Edwards. Okay, that will conclude item number 6. We will move on to item
Vice
number
Chair
7.
Shell,
Oh, yes.
Sorry to interrupt. Jessica Johnson for the record. Because this is pretty broad around administrative efforts, and I know the Clark County Task Force was mentioned before, I was hoping to just give a brief update on that effort.
Oh, please,
That
Ms.
would be
Johnson,
all right?
yes.
Thank you. And Chelsea Cheatham, who I also believe is on the call, is also a member of that task force. So Chelsea, if you have anything to add to my update, please share. So the Clark County Task Force has been meeting during this particular calendar year. The meeting frequency was established to be bi-monthly and then quarterly throughout the summer, and per the legislation is required to have a report completed the end of this year, as I think was mentioned earlier, regarding opioid fatalities and review. But the committee also has sort of a broader task with also evaluating the social determinants of health that contribute to those particular fatalities. So by way of update, not necessarily substantive, the committee met last week to begin the process of preparing the report, and solicited recommendations from all of the members, which were collated into a document live in real time on the meeting for anyone who was in attendance. By way of this committee, I think if there are folks who are interested, the Clark County Coroner has given several presentations at that meeting in detail about overdose fatalities and opioid fatalities that may be of interest to committee members here. The committee meets again on the 10th of, on October 17th at 2 o'clock. At the Clark County, I think the Clark County Chambers is the location at the government building, where we'll, I believe, do a cursory review of the report that has been prepared and in detail. So if that's of interest to this committee, or opportunities for alignment with the SURG recommendations as it pertains to Clark County, I just wanted to make sure that that update was included today and on everyone's radar. Thank you.
Great. Thank you, Ms. Johnson. Okay, so we will now move on to item number 7, which is an update on opioid litigation, settlement funds, and distribution for information and discussion only. I believe, do we have Mr. Kruger with us today? I don't see Mr. Kruger. Dr. Kearns or Kelly, do you know if anyone else may be reporting for him today?
He was supposed to be on. Let me see if I can get him.
Okay, thank you.
Chair, I just spoke with Mark Kruger. He's going to jump on and provide the update.
Wonderful. Thank you, Dr. Kearns.
Vice Chair, should we maybe take a 5-minute recess and allow people to get up and stretch their legs and use the bathroom?
I think that's a great idea. Let's do that, Dr. Kearns. Thank you. So we will now begin a 5-minute recess. Thank you all. See you back here shortly. Okay, I think we're probably okay to go ahead and get started. Mr. Kruger has now joined us, so I will turn it over to him for item number 7 with an update on the litigation and settlement funds.
Thank you, Vice Chair. For the record, Mark Kruger, I'm a Chief Deputy Attorney General with the Nevada Attorney General's Office. It's nice to see you all again. I certainly, if there's something that you would like me to highlight for this update, I'd be happy to do so. I know that we have been speaking about a dashboard of sorts for some time, so I'd like to kick it off with sharing my screen and letting you know that the state opioid recovery dashboard is up and live. So let me go ahead and share my screen. So can everyone see the screen? Kelly, we're good. Awesome, thanks. Okay, so to get to the dashboard, you would come to the Fund for a Resilient Nevada website, which is under the Department of Health and Human Services. The easiest way to find this is to simply Google it and do a search for Fund for a Resilient Nevada, and it will come up. When you want to go to the dashboard, you simply hit this top link here, FRN dashboard, and it will bring you to this screen here. It's a fairly intuitive, interactive and intuitive screen, so that it should be fairly simple to read and understand. There is some overview information here with some links, for example, to the One Nevada Agreement and the needs assessment and statewide plan being the most important. There is some financial overview, which is where I think most people will probably spend a lot of their time, as well as the goals. The general overview is the total recoveries, and it will tell you where the recoveries are. You can also select by year over here, or you can select by the actual recovery and pull it in. So it's really kind of tells everybody a total amounts that have been recovered that people can take a look at and, you know, by recovery. Up on this tab, it's a little bit tricky. It's not the goal tab yet, but right up on here, there's 3 additional tabs, so 4 total. You can actually see what the statewide recovery is. That this information gives you, instead of totals, what the actual state's portion of that total is, so that you can see how much the state of Nevada has actually brought into the Fund for Resilient Nevada. And again, it's sortable by each particular recovery, as well as the years of recovery. Then next to that is the One Nevada Agreement signatory states, and you can see they set it up in a way where you can actually see the different counties. And so it provides a total here of the share of the total amount that Nevada received that go to the different counties. And then you can select each county if you want. So we'll take Clark County, for example, here. You can also hover over it and see exactly how much they're getting, or you can push on it and it will come up here. Or you can select it over here. You can also select a number of counties and sort by year as well. So it's fairly informative, gives you an idea of how much is there. Now, the next particular one is this One Nevada signatory cities. They're working on a map for me. They don't know for sure if they're going to be able to come up with a map to actually push it where you can push the cities that are affected. But nonetheless, they have the cities separated here. Now, why is every city in Nevada not there, but every county? That's because the One Nevada Agreement has all counties participating, and only those cities that are litigating in the opioid space participating. So that's why you don't see every county, but you see a substantial amount of counties in this particular one as well. So, I mean cities, pardon me, I misspoke. So that gives you an idea of the actual income that's coming in, the financial overview. Then they have the goals, and the goals are financial goals that are provided by the Department of Health and Human Services. This has nothing to do with the Attorney General's office. We just, as General Ford has said many times, we bring in the money, we do not spend the money. So the spending of the money is done by the Fund for Resilient Nevada folks at the Department of Health and Human Services. But in each one of these, they can show you what particular vendors were served under each one of these goals and what that spending looks like. So it's kind of fairly informative. And it goes through each one that they have designated so far. Naturally, these will change. I'm going to go back to the financial overview for a second because I wanted to highlight that eventually I hope to incorporate the spending by the counties and the cities into this dashboard as well. It is not currently there. We're still working on the back end of that, and with the move that the Attorney General's office had and some other factors, it is a little bit delayed from being able to roll out with this. But I'm very, very pleased that we were able to roll out the actual dashboard, which shows your recoveries and where all these sources of funding came from. So I'm going to go ahead and stop sharing. And that was my big update for the group today. But if anybody has any specific questions, I'd be happy to answer them. As far as what the litigation looks like, unfortunately, we have not too much more of an update on the Purdue bankruptcy. The Purdue bankruptcy is currently pending in a mediation. We'll see what that looks like here in the next should be a few weeks. There has been a request to continue the mediation a little bit, which means hopefully that there's some success. We don't have any idea of what those recoveries might look like. And finally, the PBM lawsuit is still moving forward at this point. And the other litigation, the original litigation we have, is still pending because of the Purdue bankruptcy. So that's where we're at as far as the opioid litigation, recoveries, and of course our dashboard, which I'm really pleased and have to give a super big shout out and kudos to the Department of Health and Human Services, who really took the lion's share lead on getting this set up and worked with me to get the data into it and have a dashboard that looks really exciting and very, very transparent. So with that, I see that there is one question. Vice Chair.
Thank you, Mr. Kruger. I'll turn it over to Ms. Nadler.
Thank you so much. I have to tell you, thank you for that dashboard. That is the best dashboard I have seen across the country. Thank you for doing it. I check every single state, and this is you did a fantastic job, and I think it's very transparent. And forgive me because some of it cut out. Did you say that the dashboard shows which entities have received the money so far?
No, it doesn't. Mark Kruger for the record again, and thank you very much for that. I as I said, Department of Health and Human Services really did a bang up job doing this dashboard and very transparent. I'm super happy about that. Unfortunately, it doesn't track when the money was received, but it tracks when it's expected to be received. So if you see that the expected date is in the past, you can ensure yourself that that date is the date it was received. If it's in the future, that's the date it's expected to be received. And it's usually a month and day. We don't actually dial it down to the day, but the month and year. So in the past, confirmed. In the future, expected. And the reason I say expected is because, there's hopefully no defaults. Hopefully the companies will continue to pay these shares, but there's no guarantees at the end of the day. Everybody entered into these settlements with the best of intentions, and we're hoping that all of the payments will be met. But as attorneys, we have to consider all possibilities in the future. So with that said, I hope that answers your question.
I meant like the money that we've given to say, I can't even think of the monies we've given out so far. Does it break down who we've already dispersed some of our funds to?
I understand your question, Mark Kruger, for the record. So what I believe you're asking is, does it break down what the funding is actually being distributed to for programs and services? Those are in the goals sections that I showed you, and that's maintained by the Department of Health and Human Services, and it does have quite a bit of detail in there on what programs and services are being funded, and the different types of costs that are associated with those programs and services. For further information, though, I highly recommend you reach out to Dawn Yohe at Department of Health and Human Services to get additional or ask additional questions or get additional information about the actual expenditure and funding of programs and services. They have the details on that, but take a look.
Awesome job. Thank you. I mean, this is great. Thank you.
You got it. Thank you.
Any other questions or comments for Mr. Kruger? Okay, thank you again, Mr. Kruger. That'll conclude item number 7.
Great.
We will move on to agenda item number 8, which is SURG recommendations ranking process for possible action. Just for everyone to know, each of the 3 subcommittees were asked to provide suggestions for ranking recommendations, which could include keeping the system as is, or ranking at the subcommittee level, or as one subcommittee actually discussed, not ranking at all. I know with the prevention subcommittee, they liked the option of ranking by subcommittee or topic area so that recommendations from one subcommittee would not be competing with those from another. The treatment and recovery subcommittee opted to limit the number of recommendations and to rank recommendations by subcommittee topic. For example, prevention, treatment and recovery, and response. And the subcommittee did not discuss not ranking recommendations at all. And then the response subcommittee, one of their members spoke in support of not ranking the recommendations at all, but rather adding a cap to the number of recommendations any one subcommittee can submit. So based on the discussions that each of the subcommittees have had in their meetings prior to today, we wanted to have a discussion today about that recommendation ranking process and then take a vote if necessary. And Kelly, hopefully I've shared all of the details I need to share around that, unless you have more to add.
No, Vice Chair Shell, I believe that you framed it appropriately. I think what we're seeking on this agenda item is a motion on how to proceed with either ranking or not ranking, as you clearly articulated. And I'm going to leave the ranking process up on the screen so that people can deliberate on that. And I think what you're seeking is discussion and then a motion of how to proceed, which would then impact the December SURG meeting, because that would then be incorporated in to the final report, the annual report in January.
Great. Thank you, Kelly. So on that note, we'll open it up for discussion to all of our SURG committee members. If anyone would like to share your thoughts, if you have any questions and so forth.
Vice Chair Shell, Terry Kearns, if I may.
Yes, Dr. Kearns.
If I can just provide one point of clarification from the response subcommittee with the recommendation about not ranking limiting the number and not ranking, we did also propose that they be put under topic areas. So each of the prevention, harm reduction, treatment and recovery, and also response, just for clarification.
Good to know. Thank you, Dr. Kearns. Are any of our, yes.
Oh, sorry, Vice Chair Shell, this is Jessica Johnson. I just have a brief comment, if that's all right.
Yes, please, Ms. Johnson.
All right, wonderful. I have concern about not ranking recommendations. These recommendations have to be listed in an order in the report. And so From my experience with the 2022 recommendations, there was some perception that the first one listed, which was, I believe, listed due to some sort of alphabetical categorization recommendation, was perceived to be the top recommendation of the SURG. And so my leaning at this moment, and I can always be convinced, but would be to have some sort of type of ranking process, just for the sheer matter that these will be listed in some type of order. And I would hate for it to be that alphabetically one surfaces to the top, which is, going to happen, and there to be some perception from the public in any way, shape, or form. So I'm in favor of some type of a ranking process.
Thank you, Ms. Johnson. I'll turn it over to Ms. Nadler, who has her hand raised.
Yes, I 100% agree with Jessica. I got confused myself when they weren't ranked. I think it's important that we do rank them.
Thank you, Ms. Nadler. And I'll add my own comment as well. I agree with Ms. Johnson, Ms. Nadler, that I think we as a group should, be recommending that they be ranked. Any other comments, questions?
Vice Chair
This
Shell.
is Dr.
Eric Schoen.
Yes, Mr. Schoen.
Oh, thank you. I think that the ranking process, that's part of our responsibility to try to help elevate the priorities as a group, so that folks who are looking at our direction, they're counting on us, I think, to sort of, work through this process, and we're able to elevate through the ranking process some really, really good ideas. Otherwise, I think it just becomes too much noise, and so I am also in favor of retaining some sort of ranking process.
Thank you, Mr. Schoen. And I heard someone's voice a moment ago.
Yes, I'm so sorry. Vice Chair Shell, this is Dr. Shayla Holmes for the record. In addition to ranking, I am preferable to the ranking by subcommittee. As we've seen in the last couple of reports, some of the subcommittees don't end up with recommendations in the ranking or up in the ranking at all. And rightfully so, in the sense that when we are in a state where we are desperately needing treatment and recovery, I myself, as response subcommittee member, can't help but vote for treatment and recovery above response. However, I think that we are focusing on all of these things for a reason. And as we're making these recommendations out into the community, different parts of our partners out there are able to do different pieces. So I think when they're able to tailor how they're going to engage with SURG recommendations to their area, it would be ideal for them to understand what we think is most important in response, what we think is most important in treatment and recovery, and what we think is most important within prevention.
Thank you, Dr. Holmes.
Vice Chair Shell, Eric Schoen again.
Yes, Mr. Schoen.
Yeah, I would support that, because it looks like that is an approach that all three of the subcommittees advised would be acceptable. As a member of the prevention subcommittee, though, it's important for us that harm reduction and prevention are not competing with each other, just like the different subcommittees are not competing with each other. And so if we did go with the ranking by subcommittee, then I would put forward that we would have a separate harm reduction priority list and a separate prevention recommendation priority list.
Thank you, Mr. Schoen. Any comments from our other SURG members? I see Ms. Nadler with her hand raised. Ms. Nadler?
Yeah, I wanted to agree with Eric 100%.
Thank you. See Ms. Hale with her hand raised. I'll turn over to her.
Thank you, Vice Chair Shell. I'm just wondering if the SURG as a whole has any preference in terms of how the subcommittees are ordered. We kind of have set them up as, prevention, then treatment and recovery, and then response. but I don't know if there is some other method that people would like in turn, because the report still has to list one subcommittee first. That's all I'm getting at.
Good point, Ms. Hale. Thank you.
Mhm.
Any thoughts around that?
Vice Chair Terry Kearns.
Go ahead, Terry.
Yes, Dr.
Thank
Kearns.
you. I don't think it's going to really matter as much which we put first, as long as we put them, I say per topic area, which would highlight prevention and harm reduction separate, and then have it highlighted. These are ranked by topic area, which each having their separate. And my other question would then be, are each of the subcommittees going to rank at the subcommittee level and then push that up to the larger SURG for agreement on that ranking?
Any thoughts around that? Mr. Schoen, did you have a comment? I know you were trying to speak earlier.
Thank you, Vice Chair. If people were sensitive to the order, I suppose every year we could put one or the other. We could change the order that these are in, so every third year one of these subcommittees is at top. But to Dr. Kern's point, I don't think it will matter so much if we are rank ordering these per committee. I guess I had assumed, until Dr. Kern sort of raised questions, probably just asking for us to confirm, but I had assumed that each subcommittee would arrive at their own rank ordering and then sort of refer that on up to the larger committee to endorse.
Any other thoughts from our other SURG members regarding what we've already discussed today?
This is Jessica Johnson, for the record. I agree with Mr. Schoen's recommendation. I would imagine that if we are going to keep the rankings by subcommittee, that having those recommendations for the SURG to consider, given that those committee members have pretty intimate knowledge of the details of their particular recommendations, would likely make the most sense. I'm just thinking about timing wise, and maybe if staff can help guide the chairs of those subcommittees for when that might need to happen, so that we can still fulfill the legislative obligations of this group. Thank you.
Dr. Kearns, any thoughts around that, around the timeline?
Yeah, I was just going to say that I believe all of the subcommittees are meeting prior to our next SURG meeting. So that would then become a priority for each of the subcommittees to do their ranking by topic area again, in addition to each of the subcommittees. So just adding that harm reduction as a separate topic area, and then bring that back to the larger SURG meeting for that. I think it's a December 11th. SURG meeting.
Thank you, Dr. Kern. So if I'm understanding everyone correctly, so what we're saying right now is that each subcommittee at their next meeting would then rank their recommendations, bring those back to the full SURG in December for the full SURG to then vote on and carry forward. Is that correct?
Yes, that's what I'm suggesting.
Okay.
And Vice Chair Shell, just to be clear, by Eric Schoen for the record, by vote on, we mean basically sort of a vote to approve the rankings made by the respective subcommittees.
Yes, correct. Thank you.
So Vice Chair Shell, Kelly Marshall for the record. So to respond to Ms. Johnson's question, or statement about staff assisting with managing that ranking, I think as noted by Dr. Kearns, there are November subcommittee meetings. that would be a heavier lift for prevention because they would be doing both prevention or harm reduction. I thought I had potentially heard that maybe harm reduction should come to the full surge for rating, but I'm not certain about that. I think certainly harm reduction was developed under prevention, and they had access to the presentations and speakers. The one thing I would note is that your next agenda item is to review the preliminary recommendations from the subcommittees. And in previous years, we've had instances where a recommendation was asked to be revised or researched or combined with another recommendation across subcommittees. And so that just may be a complication in having finalized recommendations for the subcommittees to rank in November, depending on what the discussion is on the next agenda item.
Vice Chair, permission to respond?
Yes,
This
Ms.
is
Johnson.
Jessica Johnson. Yeah, thank you. I would propose that prevention continue to take on the harm reduction recommendations and come to this committee with our recommendations for review and blessing approval vote, rather than work them through at the larger committee meeting. Thank you.
Thank you. So if we don't have any further discussion or other questions or comments, we can certainly entertain a motion to consider. If anyone is so moved to make a motion.
Dr. Shayla Holmes for the record. I would move to rank by subcommittee, with each subcommittee to recommend ranking to the larger surge.
Okay. Thank you, Dr. Holmes. Do we have a second?
This is Eric, I'll second.
Thank you, Mr. Schoen. Is there any further discussion regarding this motion? Okay, all those in favor, please say aye.
Aye.
Any opposed? Okay, motion carries unanimously. Thank you. So moving on to item number 9, which is the subcommittee recommendations. This is for information and discussion only from each of the 3 subcommittees. So I will now turn it over to Jessica Johnson, who is chair of the prevention subcommittee. So Ms. Johnson.
Thank you, Vice Chair Shell. Jessica Johnson for the record. I'm going to be providing sort of a detailed update of what our prevention subcommittee has been up to. I'll pause after the initial prevention recommendations for questions and then cover the harm reduction recommendations, if that's all right with everyone. I wanted to start by saying, and I have my subcommittee members on the line here today, a huge thank you to all of their hard work and effort. Our goal as established this year was to really be engaged in the time that we had spent in 2023 developing these recommendations and take an effort to really identify and revisit and work on those existing recommendations instead of taking on a whole slate of new ones, trying to identify them to increase action. So many of these you'll see are sort of we're hoping a better version of what we gave you last year and continued action. So where there are changes or things are the same, my plan is to just highlight that for this review, but happy to take any questions from the committee. So the first one on the investment in primary prevention programming, there was a slight change in language in that first part to be specific about who the recommendation was going to, and that this recommendation was for the Bureau of Behavioral Health, Wellness, and Prevention to include this in their governor's budget request as a specific request regarding this investment in prevention programming. So that was the change to this first recommendation. PS2 around the tobacco control and prevention funds remains the same. committee members were able to contact the subject matter experts who presented to us on this, and this one continues to be the same per their recommendations. Number 3, the PS3 was sort of part of our overhaul around some of these community health worker and peer recommendations across the board. We looked overall from the 2023 ones to try to make these more actionable or more specific. So this one is a change in language. It would require the State Office of Medicaid to develop a state plan amendment to implement changes to support the recommendation requesting rates and billing standards for CHWs and peers to be increased to align with national average and CMS standards. The committee is, I think, continuing to workshop some of this language and recommendation. And then the 4th one that's listed on your screen here is a new recommendation. This is in the spirit of the 2nd recommendation. We have had quite a few discussions around cannabis or marijuana set aside for prevention. And so this is to create a bill draft request with that 15% set aside of cannabis retail funds to be distributing using, again, that local lead agencies model, as we saw in the PS2, to reach the $2 per capita, which is a recommended funding goal from the Nevada Tobacco Control and Smoke-Free Coalition and other subject matter experts. The prevention subcommittee did take off we eliminated 2 recommendations related to prevention. Well, I guess eliminated one and passed another one. So there was one about the braiding of funding and the braiding of dollars, and we moved that kind of into PS3 to be more specific about the recommendations. And then there was a data dashboard recommendation that was moved to the response subcommittee as it aligned with a recommendation their committee was considering. Those are the prevention subcommittee draft recommendations. I'll pause in case there are any questions from the larger SURG before I move into the harm reduction recommendations. Hearing none and nobody immediately come off of mute, I'll move into the harm reduction recommendations. So again, a similar strategy with these particular recommendations. For this first harm reduction recommendation, staff heard some information from subject matter experts in the state who have begun to implement some community drug checking. And their recommendation is really centered on this first bullet that you see here, which was to utilize a regional implementation approach with standardized statewide indicators, since really local jurisdictions were best equipped to respond to some of the findings from community drug checking. And then the other bullet points in here remain the same. On the next slide, this for harm reduction recommendation number 2, the top paragraph that folks see here is the same as in 2023. There is additional detail about the collaboration around shipping costs and some more details that are in this paragraph below in order to address any needs related to programs in rural Nevada. On the next slide is harm reduction recommendation number 3. 3, 4, and the consideration one. Great. So harm reduction recommendation number 3 remains unchanged around that saturation and really sustainability around naloxone access. Harm reduction recommendation number 4 has been refined. Again, this is a bill draft request related to legislation that will help fund and establish a statewide association for peers and 2, to better define supervision requirements for peers under the age of 18. This is analogous to one of the BDRs that Dr. Kearns mentioned before and kind of aligns in support of that. And then the committee is still workshopping one of our recommendations for consideration, which was in the 2023 recommendations around redefining, I guess, as paraphernalia as it relates to smoking supplies. 2 states, well, probably many states, but we're looking at 2 state models utilizing both Maine or Colorado as examples. The prevention subcommittee had recommended reaching out to the district attorney's office, the public defender's office, and sheriffs and chiefs for feedback around this particular bill draft request recommendation. And I believe that we've had feedback from most of those entities and are still just awaiting some final recommendation really to help refine the language or identify an opportunity to make this actionable as a potential bill draft request. So thank you to the folks who've provided us some insight to date. From these harm reduction recommendations, we did opt to take off the Maryland, the one that references the Maryland Stop Act. This from statewide experts on the Good Samaritan law was encouraged us that the details in that particular recommendation were already covered within the Good Samaritan law. So our committee opted to take that off for now and could potentially refine or revisit some actions related to naloxone access at a later date. With that, I'm happy to take any questions related to the harm reduction recommendations.
Any questions for Ms. Johnson?
Vice Chair, Terry Kearns for the record.
Yes.
On the harm reduction potential consideration about a bill draft request to change the definition for paraphernalia. Would you have someone who would sponsor that is the first question. And the second question is, were you getting positive feedback, negative feedback, or what type of feedback from the groups that you reached out to?
Thank you for your question, Dr. Kearns. Jessica Johnson for the record. No, I don't think that our committee had quite identified a sponsor for this to date. If there's anyone on the line interested in discussing more. And then from a feedback perspective, what we've heard so far was that the district attorney's group had shared that they would be in opposition of it as currently written, but had said they would provide additional feedback about what recommendations or changes that they could foresee that would move them more even towards a neutral position on this particular recommendation. And then the public defenders shared a letter that I think is posted with our prevention subcommittee where they were in favor of it as written and would recommend.
They recommended a slight change.
A slight change in the wording, as Ms. Rodriguez can keep me honest about that particular feedback. And so that's posted for the record. And we had received a couple of questions, I think, from sheriffs and chiefs by way of member Payson, who's been really fantastic about shepherding these questions for us, but no official kind of recommendation at this point.
Thank you.
Thanks for your question.
Any other questions for Ms. Johnson? Okay, thank you so much, Ms. Johnson, and your fellow subcommittee members from prevention. Those were great recommendations, so thank you. Moving on to the treatment and recovery subcommittee, I will be reporting on those today. These are not in any particular order of importance. I'll start with our first recommendation. This was brought forward by Dorothy Edwards with information that was presented to our subcommittee by Madeline Larson and Michael Berry. The recommendation is to support BDR 95 to ensure Narcan be available wherever an AED machine is located and on all campuses under our Nevada system for higher education, including in student unions, health centers, all levels of the dormitories and within residential advisors' domiciles, and include training of the administration of Narcan, which can take place during online freshman orientations, much like we already disseminate information about Title IX during orientation week. Training could be offered throughout the year by various clubs and programs within each institution's design. And I wanted to note that BDR 95 is being co-sponsored by Assemblywoman Brown May and Senator Titus. And so at the time when this was brought forward, we were not aware that the BDR was being brought forward by Senator Titus and Assemblywoman Brown May. So it was really good timing, we thought, on our part for Dorothy to be bringing that recommendation forward. We think this is very, very important item to be, implemented all across the state. And I'll take questions at the end, or I can certainly take questions along the way if anybody has any questions. Our second recommendation was brought forward by Chelsea Cheatham. It says to support access and linkage for treatment of trauma for people with substance use disorder or those who have overdosed, and for surviving family members after an overdose fatality, and to support training for healthcare professionals to identify and address trauma. And our subcommittee really believes strongly that treating trauma is an important step in supporting people with substance use disorder. And I think that's one of the reasons why we certainly wanted to bring that one forward. The third recommendation was brought forward by myself. Legislation should be considered to amend the Nevada revised statutes pertaining to the Nevada Bureau of Healthcare Quality and Compliance's employment guidelines for hospitals, including behavioral health hospitals, to hire certified peer recovery support specialists who have felony backgrounds and are within 7 years of their last felony conviction. It is recommended that individuals who were convicted of drug offenses or other offenses that do not involve violent acts or sexual exploitation be considered for employment as certified peer recovery support specialists in hospitals. One of the reasons why we wanted to bring this one forward is because there are a lot of barriers for hospitals around the state right now. We have a lot of very experienced peer recovery support specialists that can't be hired by hospitals due to the current employment guidelines. And then the fourth recommendation was actually brought to our subcommittee by Dr. Kelly Morgan, who is a physician in the state of Nevada. The recommendation is to direct the Division of Public and Behavioral Health to identify a funding mechanism for hospitals and providers to enhance the bridge program for emergency departments by incorporating peer recovery support specialists into their treatment models, and to support the use of peer support navigators via telehealth to increase access to treatment and support for individuals identified in emergency departments. So basically, we're wanting to direct DPBH to look for potential incentives of any kind to encourage hospitals to implement bridge programs that are evidence-based and have had successful outcomes around the country. So at that point, I'll conclude. Those are our four recommendations that we are bringing forward. If anyone has any questions or comments for me or my fellow subcommittee members, certainly be willing to answer.
Vice Chair Terry Kearns, for the record, if I may.
Yes, Dr. Kearns, thank you.
My first question is on treatment and recovery recommendation 1 about supporting the BDR 95. Is that specifically just targeting any facilities under the Nevada system of higher education, or is there any plan to look further at other facilities such as any place public, large public gatherings occur in like next to AEDs and say like sports stadiums or in libraries?
Great question, Dr.
Question.
Kearns. I believe that the way the BDR is currently written, it is specific to those campuses under the Nevada System for Higher Education. But Kelly and Dorothy, please correct me if I'm wrong.
This is Dorothy Edwards for the record, and I believe Steve is correct. Dr. Kearns, that currently the way it was proposed was to, for the higher education, of course, we don't know what they'll look like until they come out. And I don't remember who, and I apologize, but in one of our discussions, there was some additional questions about expanding the location and some talk about, well, maybe an amendment or something. But at this point, I think the way it was originally put forth was strictly around the higher ed.
Great. Thank you, Dorothy. Did that answer your question, Dr. Kearns?
It did. I personally would like to see it beyond just the agencies of higher education, but I guess for future recommendations. And my other question is on TRS 3 and about looking at revising NRS for hiring of peers in the hospitals. And I thought I saw in one of the updates, they talked about hiring peers in hospitals. Is it specifically changing the language, as you said here, related to the felony background in the 7 years, so that you can expand the pool?
That's correct, Dr. Kearns. Yes, we're wanting to expand the pool because right now, due to those guidelines, there are a lot of peers that are being excluded.
Thank
So
you
it
for
would
that
certainly expand
clarification.
the pool. Yes, thank you. I see Assemblywoman Thomas has her hand raised. I'll turn it over to her.
Thank you, Vice Chair, and Assemblywoman Claire Thomas for the record. On TRS 3, my question again is about the within 7 years of their last felony conviction. I take exception for the 7-year period. I was wondering, did we discuss 5 years? Because it's just I know that, we are trying to revise NRS. So if we are revising it, we can ask for the 5-year period. And I don't understand, maybe there's something that I'm not understanding. 5 years versus 7 years.
Great point, Assemblywoman Thomas. I remember that I originally had 5 years in the recommendation. And Kelly, you may certainly remember more than me this afternoon, but there was a reason why I ended up changing that to 7 years. Do you remember exactly why?
I believe Kelly Marshall for the record, and Laura Hale actually contacted Healthcare Quality and Compliance. What I believe the reference to 7 years is not as a recommendation. It's explaining what you want to change. So you originally had it as 5 years, but NRS currently states that it's within 7 years. And what the recommendation is trying to say is to change the requirements for people who have a felony within 7 years. In other words, to change the NRS from 7 years to something else. And so Assemblywoman Thomas's question, I think, may raise a point for the subcommittee, which is, do we need to be clear about what it is you want changed and to what, so that there isn't any confusion?
Great.
Excellent point, Assemblywoman Thomas. And I don't necessarily have a recommendation on that. I know we can certainly discuss that in our subcommittee, but I'm glad you brought that up today. So thank you. Any other thoughts on that, Assemblywoman Thomas?
No, sir. Thank you so much.
Okay.
Thank you,
Thank you.
Kelly.
Vice Chair Shell, Kelly Marshall for the record. I'm just not sure if Laura Hale, who directly spoke with HCQC, has anything to add.
Just confirming that you are correct, Kelly. It is what is already, we just initially misstated what was already in the legislation.
Great, thank you. Any other questions or comments regarding treatment and recovery?
Vice
Okay,
Chair
we will
Terry
move on.
Kearns.
Oh, yes,
I'm
Dr.
sorry.
That's okay.
So to that point, it's currently in NRS about the 7 years for the last felony conviction. Is there any literature or research that shows 7 years or 5 years or 3 years? I mean, I just wonder, you know, lowering it to 5 or lowering it to 3, are there other states that have implemented these programs and lowered qualifications to lesser than the 7 years? And do we know that?
I don't personally know that, Dr. Kearns. I think that would be excellent to know. I'm not sure if anyone else that means today. I see Christine Payson with her hand raised. I'll turn it over to her.
Thank you. Are you guys able to hear me okay?
Yes.
Okay, good. Just a comment. I know we've had a lot of discussions about recidivism and what exactly the definition would be. And I feel like if we could nail that down, like what does it mean? Because it varies from state to state and county to county, then you would be able to have some more data to say, look, you know, 5 years from offense isn't any better or worse than 7 years from the offense. If you could get that definition nailed down, then you'd be able to get some good data to back up what your time frame should be.
Great. Thank you for that, Ms. Payson. I see Ms. Nadler with her hand raised.
Thank you for all y'all put together. I love this. I have a question about TRS-4. And I don't know if this will fit in there, and I hope I explain this the way I'm thinking of this. As far as the bridge program, I'm just thinking of something. I know we've got a lot of kids going into the emergency room and leaving, but we also have a lot going into jail and leaving in 2 days. Is there some kind of, can we somehow do something to incorporate that bridge program for kids who have been arrested and then set out on the street? Does that make sense? I talk to so many kids who've been arrested, they're put back out on the street after 2 days and they have no help. There's no support for them. Can we do something with this bridge program to people who've been arrested and then released? Or
Ms. Nadler, thank you for bringing that up. I know we were very focused on emergency departments, but I think you raised an excellent point about the jails. I'd be curious to, if Dr. Dixon is still with us, to see what her thoughts may be.
Okay, it's Dr. Dixon for the record. I don't know that anything right now is being done with minors in terms of like the, what is it called, juvenile detention and things like that. Because only in the last year have we taken on the prisons and the jails, the regular jails. And so we have a team at CCDC that works with people to get them on into treatment. I had a new patient from that program today. And then the same thing with Department of Corrections. They are delivering, we are delivering the material for the long-acting injections for buprenorphine. And and all this is because we did get some grants to support that. These are expensive medications. And but I don't know. I guess we have to have somebody who wants to take on working with juvenile detention. But we don't normally put adolescents on buprenorphine anyway, or certainly not methadone. And to start doing that would probably require a real change in how we deal with adolescent drug abuse.
Thank you, Dr.
Chair,
Dixon. Oh, yes, Dr.
Terry,
Kearns.
this may answer some of Ms. Nadler's question. In the response subcommittee, we've had presentations from Bill Teal, who's a retired captain from Las Vegas Metropolitan Police Department and is working under the direction of Don Yohe with the Fund for Resilient Nevada. And I believe that's where the funding for this program is. He started by doing an assessment it's looking at the rural frontier jails to see if they had MAT or MOUD programs in place. If they didn't, what were gaps? What did they need in order to start the implementation of these programs, looking at adults? So he continues to give us updates in the response subcommittee. I believe he's got a pilot that's going to start in Lander County soon to address this, but also expanding it to the other counties with the idea of hopefully getting it to all of the rural and frontier counties. Washoe and Clark already have programs in place. And then I met with him just yesterday, and he told me that the second phase of this is looking at a similar program for juveniles. Not in the process yet, but something they hope to do in the future. And that came from a recommendation. It must have been from 2022 about having the 3 FDA approved MOUD medications available for those in carceral settings.
Oh, that's great. Thank you. Thank you.
Vice Chair Shell, this is Dr. Shayla Holmes, if I could for just a second.
Yes, Dr. Holmes.
I just wanted to share that at Lyon County Human Services, we are piloting exactly this within our FAST program. So we do have 2 peer recovery support specialists being assigned to individuals upon release from our local jails. So this does have a mechanism right now within existing FAST programs, which were also identified in the DHHS report out earlier on.
Thank you, Dr. Holmes. And I wanted to go back and recognize Ms. Payson. I know she had her hand raised. I'm not sure if she still has a comment or question. Okay, I'm assuming not. Any other questions or comments regarding treatment and recovery?
Yeah, that's Dr. Dixon again. I guess we need to resolve the issue of medication treatment in adolescents. I have asked my clinic director, we would probably take someone as from 16 or older. Dr. Adelson her clinic has done methadone with teenagers because she's had grant money from the federal government, but it is not traditionally done. And I don't know if I think we need to get more input from pediatricians, because I don't know if there's any addiction specialists in the pediatrician community. Probably not. And so I think we need to be careful about thinking about doing something that medically is not done on the outpatient side of things.
Thank you, Dr. Dixon. I see Ms. Payson has her hand raised. I'll turn it over to her.
Thank you. I've been periodically losing my feed, so I heard my name, lost sound, and then came back. So I don't know why my name was mentioned, if there was a question for me.
No, I saw your hand raised. I didn't know if you still had another question for us or another comment.
Okay, no, I'm good. Just losing my feed every now and then.
Okay, thank you. Okay, so we will move on to the response subcommittee, and I will turn it over to Dr. Kearns.
Thank you, Vice Chair. This response subcommittee basically had a combination of trying to revise or update some prior recommendations and also some new recommendations for a total of 5 recommendations, as you see on the sheet that was provided. The first is RS1, which is a new recommendation, and to the point that was already addressed about having a definition of recidivism. We recommend that state agencies under the legislative, judicial, and executive branches involved with deflection and diversion programs have a comprehensive definition of recidivism and policies related to measuring and reporting recidivism. We originally started by stating we wanted a BDR for a statewide definition of recidivism, but after discussion and some presentations, we found that the Nevada Department of Corrections currently is the only one in the state who has a definition of recidivism, and that involves a return to prison within 3 years. but that definition would only work for people who are in prisons, and that it would not include more arrests, and also trying to look at, should we look at 3 years or more than 3 years, as some of the feedback that was provided to us. And we feel that it's important to have a measure of the effectiveness of criminal justice system efforts to promote rehabilitation, reintegration, and public safety. And recidivism rates are not available at the national level. And since there is no national consensus on the operational definition of recidivism, and there are significant variations in how it is defined and counted, we're looking at whether that be recontact, rearrest, reincarceration, or reconviction. So that's why we think it should be pushed out to the state agencies that are funding and supporting programs that involve deflection and diversion, so that they can be measured against each other. And what I mean by that is in dealing with the most and fast teams, it's really hard. We're kind of comparing apples to oranges because the definitions of recidivism do differ from county to county. So that's why we are recommending now that each state agency that deals with the diversion and deflection programs do develop these programs and develop definitions so that they can push those down to the programs that they fund, or that the programs that they can fund can use those definitions then. I'll take any questions on that if there are any. Hearing none, I'll go on to our next recommendation. Recommendation number 2 is basically revision of a prior recommendation about having the Office of Analytics out of DHHS to have a dashboard. What we now recommend is recommend research into the implementation of a statewide data sharing agreements with the Chief Data Officer of the state of Nevada, and implementation of a cross-sector database housing multiple points of data across prevention, treatment, recovery, and criminal justice, to include data such as controlled substance outlets, tobacco, cannabis, and alcohol, to help tailor interventions geographically. And this was also with the input from the prevention subcommittee about those outlets. So this is an overarching issue with data sharing and accessibility of data. We had a presentation from the Commonwealth of Virginia on their successful efforts to have this comprehensive dashboard. And we also incorporated the prevention subcommittee recommendation on including tobacco, cannabis, and alcohol outlets. The Virginia, it's called the Framework for Addiction Analysis and Community Transformation, or FACT is the acronym. It's a secure data sharing platform that's led by their Department of Criminal Justice Services in collaboration with their Chief Data Officer. And it combines previously siloed data from different agencies, secretariats, localities, social services, public safety and corrections, drug courts, community coalitions, and private healthcare systems. It generates insight about contributing factors, brings awareness, and delivers actionable intelligence to community leaders, supporting their timely and effective response. So that's our second recommendation. If there's any questions on that. I should add also, we have been in contact with our Chief Data Officer from the state to ensure that they are in alignment with this recommendation.
Vice Chair Shell, I have a question, if that's all right.
Yes, please.
Thank you. Jessica Johnson for the record. On this recommendation number 2, is in my understanding of it, is this like individually identifiable level data? Is this community level? So kind of at what level is in the vision of this recommendation would the committee suggest?
I'm going to defer to Vice Chair Shayla Holmes, who pushed this one forward.
Thank you, Dr. Kearns. Shayla Holmes for the record. The Commonwealth of Virginia does take up all levels of data as available by those individual entities. And when it is identifiable, they de-identify it. And that is done through individual MOUs directly with the chief data officer of the state. So each entity that participates in this data sharing has that standardized MOU directly with the chief data officer. And so that information is shareable directly from that agency to the chief data officer, who then their staff de-identifies it and pushes it back out into the dashboard. And by doing so, that allows them to be able to identify individuals' pathways without identifying the individual. So knowing if a intervention method that was utilized was successful and for how many people and how many different touches they had along the way within the various systems that interweave when you talk about prevention, treatment, recovery, criminal justice, etc.
Thank you.
You're very welcome.
I see Ms. Hale with her hand raised.
Thank you, Vice Chair Shell. I just wanted to get clarification. The reference to the Chief Data Officer of the state of Nevada, what is that person in a particular agency or division, department?
Shayla Holmes for the record, that individual lives within the governor's office, so they are their own entity, their own office.
Thank you. I hadn't heard of it before, so I just wanted to make sure it was clear. Thank you.
Great.
If
Do
there
we
are
have
no
any
other
other?
question-
Oh, sorry, Dr. Kearns.
No, that's fine. I was going to say, if there are no other questions, I'll move on to response subcommittee recommendation number 3, which is a revision from the update that Ms. Hale gave from number 20, the wastewater-based epidemiology. Recommendation number 3, support the collaborative proposal to the Fund for Resilient Nevada to conduct sampling of high schools, college, university campuses, and bars, nightclubs, and use information gained to develop public health awareness programs, deploy targeted naloxone, increase provision of fentanyl test strips to targeted locations, and to develop a plan for expanding high-risk substance wastewater surveillance in our state, and review the outcomes from the pilot program to identify if it and similar targeted programs may aid in the community response. I would add that this was a refining of the prior recommendation that was not ranked from last year. We were able to research this more and had presentations that included information on other states such as New Mexico and Virginia that are successfully using substance wastewater surveillance. And we also had a presentation from UNLV, Southern Nevada Water District, that they did submit a proposal to the Fund for Resilient Nevada, and they did update us that they are in negotiation for terms and funding for this project from the Fund for Resilient Nevada. I'll pause if there's any questions.
Vice Chair Shell, this is Jessica Johnson for the record. If I can ask a quick question.
Ms. Johnson.
Thank you. When I initially read this recommendation, I just have like a small wording proposal in that first sentence when it just says conduct sampling. I'd recommend saying wastewater sampling in that first sentence. I initially had thought that you were doing like micro data collection at high schools and universities, and it took me a moment to really get down to the wastewater piece. So thank you for that consideration.
Thank you for that. If there are no other questions, I'll move on to our 4th recommendation, which is revising a previous recommendation. The resolve the conflict between the Good Samaritan Drug Overdose Act and drug-induced homicide law. Immediate actions may include recommending community level education using best practice guidelines, as well as education for law enforcement personnel, and exploring options for altering the Good Samaritan language to expand coverage to a greater population of individuals living with substance use disorder. As I mentioned, this was a revision from previous year. We did have a presentation from CASAT, who provided updates on education on both the Good Samaritan law and drug-induced homicide. And in saying that, there was still a feel from the committee members that altering the Good Sam language to expand coverage for a greater population of individuals living with substance use disorder, because people still don't always feel comfortable calling 911 when they witness an overdose, or as also was highlighted here today by Dr. Dixon, or also seeking additional treatment after they've experienced an overdose. So that was why we felt we should revise this and push it forward again. I'll pause for questions. Hearing none, the fifth recommendation was from Senator Stone to implement a voluntary program to install drug take-back bins in retail pharmacies. And Senator Stone highlighted how this was successfully accomplished in California and is just another way that people can dispose of their drugs to get rid of these medications out of their medicine cabinets and decrease the potential of them getting diverted. It was noted that people don't always feel comfortable going into a law enforcement facility to dispose of their drugs. So this would just provide another option, and keeping legal controlled substances prescribed for patients that have expired or not being used from being diverted for sale and consumption, and also keep them from being disposed of down people's toilet, which then gets into our water system. And that was our fifth recommendation. If there's any questions on that.
Dr. Dixon.
Dr. Dixon.
I just want to make a comment. I worked a drug take back day in front of one of the grocery stores several years ago. We didn't get very many controlled substances, but we got tons of everything else, which is probably a good thing, because those medications are generally can't be considered totally harmless. But so I guess you'd have to have a plan to empty the bin about every other day.
Thank you. Other questions? Hearing none, what I would like to last highlight is that the response subcommittee may put forth an additional recommendation relating to overdose fatality reviews in alignment with a prior recommendation to review the operations and lesson learned from Clark County's Overdose Fatality Review Task Force, or their opioid task force, and because they are to release their report in December of 2024 and take this into account when supporting legislation to establish regional overdose fatality review committees, allowing flexibility as to the makeup and practice, and for the OFR to remain at the county or regional level as needed to effectively identify system gaps and innovative community specific overdose prevention and intervention strategies in accordance with established best practices such as the Bureau of Justice Assistance Overdose Fatality Review, a practitioner's guide to implementation. And we will be receiving a presentation from the Clark County Task Force at our next meeting. So we just want to highlight that we may have one additional recommendation.
And Dr. Kearns, I see that Ms. Hale has her hand raised.
Thank you, Vice Chair Shell. Is actually a question for Dr. Dixon, and for the notes, I couldn't quite make out what she was saying about something that was put into the drug take back at one of the grocery stores. I just wanted to get it clear for the minutes.
Yeah, Dr. Dixon, for the record, in other words, people brought in lots of other medications that were not controlled substances. In fact, I have to say, yeah, so I just want to add a little time, remembering that one of the other doctors that worked with me that day, he used it as an opportunity to empty out his sample drugs that have been donated from him by the pharmaceutical people, and that was a lot of medications. So I think, yeah, we just need to think about what we're proposing in terms of giving people a place, because we know a lot of people know not to put this in the water, in any drug in the water system. So
thank you.
Any other questions or comments for Dr. Kearns? Okay, thank you again, Dr. Kearns, for those great recommendations from the response subcommittee. We will move on to item number 10 on our agenda, which is to review the layout of the annual report template. This is for information discussion only, so I will turn it over to Ms. Hale.
Thank you, Chair Shell, Vice Chair Shell. Thank you for bringing up that screen. If you can scroll down to the first page there, or I'm sorry, to where we've got the content. So past the table of contents and yeah, there. So this part is should look familiar to everybody because there are essentially no changes. This is just setting up the purpose and how the different subcommittees were structured. And there is a footnote there as well for when we added the harm reduction work. And this is just information tying back to the original legislation, AB 374, Section 10, which says these are the things that the SURG must do. So we can go scrolling down. So this is all about what the recommendations are to be put into that section with the placeholders. And then, thank you. So that's where you see all those placeholders. That's when you come up in December with this, when the SURG meets again and reviews what the subcommittees have put forward. This will go as you recommended or approved that it would go according to subcommittee. So that's what you will see here. So now you can go down to the next screen, please. So this is the methodology, which is going to be the same. We've got our current chairs listed there, and the roles of everyone is very much the same. The ranking recommendations will be updated to reflect your discussion from today, how that came out. And then scrolling down, that's the section that will have more of the recommendations filled out, your action steps, background, so forth. I'm kind of losing track of where you're going there. Okay. So then the next section down. So these are all the different appendices, and there will be attachments for those. So under Appendix D, I mean, I think most of these are self-explanatory. Additional information, research links, target population impact, legislation address. So that takes care of ABC. Appendix D, the status of previous recommendations. So we would have an as of the date that we get those, which would most likely be what we reported out today. And today was 2023. We did talk about how we might handle this, you know, going forward. How many years forward do you carry? At some point, you know, you need to have a cutoff there. So, but we just wanted to, I guess, check in with the SURG members about that because, well, as you just saw with the subcommittees reporting out on those new recommendations, sometimes they will bring things back in for consideration or follow-up work. So that can occur, but as the SURG goes forward in many years, you wouldn't necessarily want to try to tackle updates for every recommendation going back to 2022. So I don't know if anybody has any questions, comments, concerns about that. Okay. So Appendix E, information regarding SURG membership, structure, activities that will, you know, just have new people who have been appointed to the SURG, but otherwise will look like our report did last year. And then the settlement funds so this new tracker that was given us, we got the report on earlier that's sitting in the director's office under the Fund for Resilient Nevada, that's the link that will go there, which will be great because people can get updated information as they want it. Scrolling down, I think the rest of it is just different, examples of the different tables. So all of that gets populated with the information that you've all put into your recommendations. A legend will be inserted there. This is, all of the detailed stuff from the original legislation. So then we just match up by the recommendations, which specific elements of the original legislation they are linked to. So a lot of work tying this in, but I think worthwhile so people can see how this ties back to what the SURG is being tasked with doing. I don't know, Kelly or other people on the staff want to add anything else to what I've said about the report? I think that's it, Mr. Chair.
Thank you, Ms. Hale. Any questions or comments from any of our SURG members?
Vice Chair Shell, I'm sorry.
No, go ahead, Dr. Kearns.
I was just going to say, I really like the template that was used and think it's right on track. The only thing I was going to highlight is on the part that lays out the subcommittees is maybe even having a statement as was so brilliantly highlighted by SURG committee member Schoen, is that these are in no particular order, that we are just putting the subcommittees down there and then by topic area.
Great, we can do that. Thank you.
Great, thank you so much, Ms. Hale.
Vice Chair Shell, Jessica Johnson for the record, if I may.
Yes.
Ms. Hale asked a question about how far back we should add reports. I don't know how others on the committee feel about this. My recommendation would be to add the previous years and then if possible and feasible for staff, bless you, then add links to ones previous to that for any reference, but open to suggestions from the committee as well. Thank you.
Yeah, so it's certainly easier to add links than try to update all of that information. So yeah, we could give a link to the previous year's report, certainly.
I like that as well. I'm glad Ms. Johnson brought that up, so thank you. Anything else for Ms. Hale? Okay, thank you, Ms. Hale. We'll move on to item number 11 on our agenda. This is a review and consideration of items for the next meeting for discussion only. So I'll turn it back to Dr. Kearns.
Thank you. So our next meeting is, I think, going to be primarily really focused on trying to get our recommendations together for the annual report, which, if you'll remember, is due the end of January of 2025. So we put on here to review the annual report template if necessarily. We were just afraid we might not be able to get to that today, but we were able to do that. So if there's just any updates, we can have that. Then also to review, discuss, and finalize the recommendations and have the ranking of the recommendations prepared for the annual report. So as we decided today, I think the decision was that each of the subcommittees would internally rank the 4 topic areas based under their subcommittee. And so what I mean is harm reduction and prevention under prevention, treatment and recovery for treatment and recovery, and then response under the response. And then, as usual, an update on the opioid litigation settlement funds and distribution. So that's what we had. Are there any other items that we should consider for the December 11th SURG meeting? Hearing none, I think we're all prepared for the recommendations for the annual report for that meeting.
Great. Any other questions or comments for Dr. Kearns? Okay, thank you, Dr. Kearns. We will move on to item number 12 on the agenda, which is public comment. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241.010. So Kelly, do we have anybody wishing to make public comment?
So I see Stephanie Cook would like to make public comment.
Yes, Ms. Cook.
Hi, Stephanie Cook for the record. Very thankful to see y'all and participate in this. I just want to mention if anyone ever has questions or concerns about any of our grants, I'm happy to have those conversations. I do want to comment on one of the recommendations about our budgets. And so all the executive branch budgets were due to the governor, due to our director's office, August 30th. So I did see a recommendation to include something in our updated budget. So I just want to mention that our budget's already submitted for state fiscal year 26-27. But happy to have any conversations of anyone with questions regarding to our grants or where we're spending our money and how we're doing it. But thankful for this committee and all the work that you all are doing.
Great, thank you.
Vice Chair Shell, I don't see any other hands raised currently.
Okay.
I don't know if you want to ask if there's any public comment physically in Southern Nevada and Las Vegas or in Carson.
Yes, do we have anyone in person in Las Vegas or Carson City wishing to make public comment?
Giuseppe Mandel, Desert Hope and American Addiction Centers Treatment Center. Just want to thank you guys all for your time. Your work does not go unnoticed by the public. And so just a moment of gratitude and say thank you.
Great, thank you for that. We appreciate it. Anyone else from Southern Nevada or Carson City? Okay, it looks like that concludes item number 12 on the agenda for public comment. Item number 13 is our adjournment. So we will adjourn this meeting and look forward to seeing everyone at the next SURG meeting in December. And in the meantime, please take care. Thank you all.
Thank you.
Thank you.
December 11th.